This talk is about blink reflex test interpretation. Test 3. As we saw in blink reflex test interpretation, test 1 and 2, I use 7 steps to interpret blink reflex test. The first step consists of creating a platform to display results in a visually clear fashion. Step 2 is to gauge the scale used to display the waves. Step 3 is the assessment of R1 responses. Step 4 is the assessment of R2 contralateral responses. Step 5 is the assessment of R2 ipsilateral responses. Step 6 is to compare R2 ipsilateral and contralateral triggered by the same stimulus. And Step 7 is the writing of the report. Step 5 and Step 6 can be omitted if Step 3 and 4 yield unequivocal normal results. So let's get to it. This is the usual presentation of a blink reflex test waveforms, but you may also encounter this representation. The approach is the same. The first step when analyzing blink reflex test waveform is to create a platform that displays the results in a systematic and clear way. I find this arrangement satisfactory, but we will go over the positioning of each of the elements because of the new wave presentation. Right supraorbital nerve stimulus corresponds to the right test. The first wave on the side of the stimulus, in this instance the right, is the right R1. The second on the side of the stimulus is right R2 ipsilateral. Both of these waves reflect right orbicularis oculi activation. Be aware that R1 is not associated with the visible response of the orbicularis oculi. The only wave from the left orbicularis oculi following right-sided nerve stimulation is R2 contralateral. The left supraorbital nerve stimulus corresponds to the left test. The same arrangement goes for left R1, left R2 ipsilateral, and left R2 contralateral. Step 2 is to determine the scale used for wave representation. As you can see, each horizontal division is 10 milliseconds and each vertical division 0.5 millivolts. Step 3 consists of interpreting R1 responses. I start with the left test, looking at the left R1 onset latency and decide if normal or abnormal. I have now introduced the normal values for R1. The left R1 onset latency in this study is 9 milliseconds, which is normal. Then I look at right R1 onset latency. Right R1 onset latency is 11 milliseconds, which is normal. Now I compare left and right R1 onset latencies. The result is 2 milliseconds, thus abnormal. It indicates delayed onset latency of the right R1 and normal left R1, which are now reflected in the display platform. This should tentatively be interpreted as a possible abnormality involving the trigeminal nerve, lateral pontine region, the facial nerve, or a combination of these structures. I have represented this area in yellow. I then take a step 4. It consists of the evaluation of R2 contralateral. I start by assessing left R2 contralateral. In this frame, I have introduced normal values for R2 contralateral from different sources. Equal or less than 42 milliseconds is from our lab's control, which we will use for this exercise. Left R2 contralateral is 30 milliseconds, less than any control. Then I assess right R2 contralateral, onset latency. Right R2 contralateral is 40 milliseconds. It is less than any control. Then I compare the two R2 contralateral onset latencies. They are 10 milliseconds apart, which is abnormal, rendering the one with the longest onset latency abnormal. In this case, the right R2 contralateral is abnormal and left R2 contralateral normal. This is then used to populate the appropriate fields in the display panel. We will now see the implication of these results by adding them to the previous diagram constructed based on R1 responses. In this frame, you can see reproduced the pictorial depiction of the tentative conclusions arrived based on the interpretation of R1 responses. I have now highlighted in green those structures proven normal based on the normal left R2 contralateral response. Most revealing is that the facial motor nucleus and the facial nerve motor fibers going to the orbicularis oculi are normal, and in yellow those tentatively considered abnormal based on the abnormal right R2 contralateral response, which are the right spinal tract, the caudal region of the right spinal nucleus of the trigeminal nerve, and the fibers that from there ascend to the contralateral facial motor nucleus. Now we go to step 5, starting with the evaluation of the left R2 ipsilateral onset latency. Left R2 ipsilateral onset latency is 32 milliseconds, normal. Then I go to evaluate right R1 ipsilateral. Right ipsilateral is 43 milliseconds. This is abnormal. Then I compare the onset latency of both R2 ipsilateral responses. The difference is 11. The longer R2 ipsilateral onset latency makes it abnormal. So we populate the display with the later responses. The impact of these results on the overall interpretation of the blink reflex test can be illustrated using the last drawing of the brainstem, as you can see here, and adding a green background to those additional structures proven normal by the normal left R2 ipsilateral response. The left track and interneurons communicating the left spinal nerve caudal nucleus and the ipsilateral facial motor nucleus. On the other hand, the abnormal right R2 ipsilateral further supports a complete right afferent deficit. The most likely single site for the functional lesion producing this defect is the incoming fibers from the trigeminal ganglion, but a trigeminal ganglion lesion or trigeminal nerve lesion are also possible. We have just finished step 5, but since nothing will be gained by step 6, it can be omitted. Hence, we go to step 7. Step 7 consists of writing a report, which should state that blink reflex is abnormal. It supports the presence of a right-sided functional abnormality involving the proximal sensory trigeminal fibers before splitting into those traveling towards the main and spinal nuclei, the trigeminal nerve or ganglion. Just before saying goodbye, let's say a few words about amplitude and amplitude asymmetry. I give no practical significance to bilateral low amplitudes, but consistent amplitude asymmetry of more than 70% probably constitute, even in the absence of any latency delay, a significant abnormality consistent with axonal loss. Thank you very much for your attention.